Recording in progress.
Question and answer, Prof. Okay, maybe we can proceed, Prof, to the this meeting.
Okay, thank you. So, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Very good morning to everyone. Thank you, Dr. Arfiza, and thank you also to the head of department, Dr. Andrina and Dr. Devira, for inviting me. Okay, so I'm going to give a lecture on hoarseness and the overview of the management. Let me share the slides. Okay, it looks like not all the participants, your residents have joined. Are there going to be more, or can I just start? Cannot hear you.
Maybe we can proceed, Prof, because we record this video. Maybe they can see the video after the recording, Prof. So maybe we can proceed. More resident will become, but we can proceed, Prof.
Okay, right. So this is the topic. The content, a little bit on introduction, and in this lecture, I'm going to focus on these three main topics: management on structural voice disorder, which basically the benign vocal Follicions, neurological voice disorder, and functional voice disorder. I'm not going to cover the vocal cord palsy, unilateral, and as well as the treatment for malignant vocal Follicions in this lecture, because it will be covered in different lecture. And within this lecture, we're going to discuss on medical, surgical, and voice therapy for the voice disorders. Voice is complex. It is produced by interactions between respiratory, laryngeal, and resonance system. This is a repetition. I've given this, I think, in the first lecture on voice and speech. Okay, the spoken word consists of three components: voice sound, resonance, and articulation. Then it becomes a spoken word, a meaningful spoken word. Okay, so voice sound is just a sound produced by at the level of the larynx, at the vocal fold, and when the vocal fold is vibrating, so it produces voice sound. And the resonance is when the voice sound is amplified and modified by the resonators. What are the resonators? The mouth cavities, the throat, nasal passages that make the sound unique for certain patient. I mean, certain person, like Dr. Arfiza, I have different voice sound. Yeah, I also have different voice sound. And the articulation would make the spoken or the voice sound, which is amplified, meaningful and become words. Yeah, the tongue, soft palate, teeth, make the voice sound, the amplified voice sound become meaningful. Yeah, become meaningful words. So when we talk about hoarseness, we are talking about disruption at the voice sound. Okay, we are not talking about disruption at the resonance or articulation. When someone have hypoglossal nerve paralysis, the voice, the speech will be slurred. We don't say that the patient has voice disorder. We say that the patient has speech disorder. Yeah, slurred speech. All right. Someone who have a cleft palate, for example, or weakness of the soft palate, we don't tell the patient, say the patient have hoarseness, but we tell the patient has problem with the speech. There's a hypernasal speech, yeah, rather than hoarseness. Okay, hope we can grab this concept. And for voice production, which is mainly here, okay, So maybe what do you call that? The more accurate word here is not voice production, but speech. Yeah, which you need a lungs, good lungs, vibrator, which is the vocal fold, articulator, and resonator. So just to show this video. So hope you still can remember, okay, what could disrupt, what is the physiology of vibration of the vocal fold, okay, and what are the layers of the vocal fold, okay. Any disruption of the layers of the vocal fold, the mucosa, superficial lamina propria, the vocal ligament, which consists of intermediate and deep lamina propria, and the body, which is the muscle in the paraglottic space over here, would disrupt the vibration. When the vibration of the vocal fold is disrupted, the voice, okay, hoarseness would occur. Okay, what are the causes of hoarseness? These are the long list of causes of hoarseness, but the one that I have underlined in red are the common ones. Yeah, infection, vocal abuse, laryngopharyngeal reflux is a common. Neoplastic, it's the commonest is squamous cell carcinoma. Neuromuscular, or some people call it neurological disorder, like nerve paralysis. Okay, there's something that I want to correct here. I purposely put it here, but I want to tell you this is inaccurate, the classification. Primary muscle tension dysphonia is not what do you call that, classified under neuromuscular. Muscle tension dysphonia is classified under functional voice disorder. We're going to discuss a little bit more after this. Psychogenic is not under neuromuscular. It is more of a functional voice disorder. Okay, there's nothing wrong with the neurological function in voice production. Okay. However, spasmodic dysphonia, Parkinson disease, nerve injury, myasthenia gravis are categorized or classified under neurological or neuromuscular disorder. Whereas the muscle tension dysphonia, psychogenic, okay, it is classified under psychiatric or functional, or some people call psychogenic voice disorder. Okay, when someone, a patient come with hoarseness, taking good history is very important, because at the end of your history taking, you should at least be able to have some list of differential diagnosis. What is the cause of the hoarseness? So therefore, history taking is very important. The duration and the onset of hoarseness. Acute onset of hoarseness, there are a list of differential diagnoses compared to chronic hoarseness. Yeah? And you would want to know whether the patient have any infective symptoms, like URTI, upper respiratory tract infection symptoms, like rhinorrhea, sore throat, cough, yeah, fever. If it is acute onset and there are signs or symptoms of infection, you may think of acute laryngitis. Someone who have acute onset of hoarseness and there is recent abuse or trauma, like the patient went to karaoke and then used the voice a lot, or went to a game and scream a lot, and after that have hoarseness, then you would think about vocal hemorrhage. You would think about hemorrhagic polyp, something like that, yeah, or acute laryngitis due to trauma. And in the history, if the patient give history of high risk behavior or any risk factors of malignancy, you should think about that in the differential diagnosis, especially if the hoarseness is more than 3 weeks, chronic, yeah, 3 months, 4 months, 6 months, yeah. When someone have history of smoking, with or without alcohol consumption, patient will have marked laryngeal laryngopharyngeal reflux symptoms, or in patients who have occupation which are at risk of developing malignancy, like carpenters, yeah, people who work in a lab with exposure to chemicals and they don't wear proper protection. Yeah, those patients are at risk of having malignant lesions on the vocal fold. And also in the history, you want to ask any symptoms that may suggestive of malignancy. Like, for example, if the malignant tumor of the vocal fold has spread regionally in the larynx, for example, the tumor has gone to the hypopharynx, so the patient would complain of dysphagia. If the tumor has caused fixation of the vocal cord, the patient would have a reduced effort tolerance or noisy breathing or difficulty in breathing. If the patient have advanced tumor and have spread of disease in the neck, the patient would complain of neck swelling. So those kind of symptoms you would want to ask in the history. And of course, you ask about the occupation, whether the patient has high voice demand occupation that may be a risk factor of developing benign vocal Follicion, or the occupation itself is a risk factor for the patient to get malignant vocal Follicion. And in the physical history, you examine whether the patient have any signs suggestive of infection. Does the patient have any noisy breathing, any stridor, any stertor, and SENT during physical examination? You would want to examine the vocal quality, the GRBAS. Hope you still remember the first lecture on basic voice assessment. You examine when you listen to the patient's voice, okay, is it breathy voice, is it rough voice, is it asthenic voice, and what is the severity? And you examine the maximum phonation time. A reduced maximum phonation time would suggest there is a glottic insufficiency. The glottic insufficiency can be due to vocal cord paralysis, or it can be due to big lesion on the vocal fold that impede the glottal closure. That also can cause reduced in maximum phonation time. So that is something that you need to examine. And examine the neck, whether the patient have any masses in the neck, whether the patient have any thyroid swelling. Thyroid swelling, if it is malignant tumor, it may infiltrate the recurrent laryngeal nerve, causing vocal cord palsy. And if the patient has surgical scar, okay, you may think of vocal cord paralysis, for example, thyroidectomy scar, anterior cervical spine scar, esophagectomy scar, for example, may suggestive of the patient has vocal cord or recurrent laryngeal nerve injury. And lung examination is important, especially if the patient is a smoker. The patient may have metastasis to the lungs, or patient may have concomitant carcinoma of the lungs, right? And patients who have, what do you call that? This is my WhatsApp. The patient who have, for example, lung findings, okay, at the same time have hoarseness, okay, you may think about tuberculosis, okay. Patient may have chest X-ray shows cavitation of the lungs, and when you examine the larynx, you see lesions, yeah, which may be a TB laryngitis, okay. So those are the things that you need to examine during physical examination, okay. And now we're going to go on the specific topics, okay. First, we're going to discuss on benign vocal Follicions. So in the benign vocal Follicions, by the time you finished history taking and you have finished examining, doing endoscopic examination of the patient, by this time you would have identified some predisposing factors, like whether the patient is a smoker, whether the patient take alcohol, whether the patient have symptoms of allergic rhinitis and any signs of allergic rhinitis when you examine the nose. When you do flexible nasopharyngeal laryngoscope, for sure you would go through the nose first, look for signs of allergic rhinitis, and whether the patient have any laryngopharyngeal reflux signs. Okay, so when you have identified these predisposing factors in managing benign vocal Follicion, you have to treat this condition. If the patient is a smoker, tell the patient stop smoking, stop taking alcohol. If the patient have allergic rhinitis, laryngopharyngeal reflux, please treat this condition. And now the question is whether you want to treat the allergic rhinitis first or laryngopharyngeal reflux first. Okay, that is something that you need to think. Let's say the patient has post-nasal drip and there are signs of chronic laryngitis and the patient has vocal fold nodules. Then you may want to think, should I give the patient proton pump inhibitor, treat the LPR, or you want to treat the allergic rhinitis? So you go back to the history. What is the marked symptom? Is the nasal symptoms more marked? Or if the patient do not have nasal symptoms, but yet on examination you see post-nasal drip, and in the history patient more complain of throat clearing and foreign body sensation in the throat. So you may want to treat possible LPR first. Okay. Or if both are patient have both marked symptoms, then you may want to treat both at the same time. And when you have benign vocal Follicion, of course you need to remove the pathology, but not all the time. So we're going to discuss this. And after this, I'm going to discuss what is the therapy, what is the role of voice therapy. Okay. And for singing patients, of course, you need to tell them, treat the condition, and when they want to start singing again, if they don't have any vocal classes, they need to go for vocal classes to prevent the same problem recur. And you need to educate patient on vocal hygiene. This is something not all people familiar with this, but this is very important when you treat patients with voice disorder. Vocal hygiene, yeah, read about this, and you need to educate your patients who have voice disorder with regards to vocal hygiene. Either the vocal hygiene will treat the benign vocal Follicion, or the vocal hygiene would prevent recurrence of the problem after you have treated the vocal Follicions. So now, when patients have lesions on the vocal fold, when there are big lesions, voice therapy is not effective. For example, you have big vocal fold cyst, you have big vocal fold polyp. Voice therapy is not effective. It wouldn't reduce the size of cyst, big cyst. It wouldn't reduce the size of polypoidal lobulated polyp. But voice therapy still have a role. You want the patient to see SLP before you do the surgery, because you want the patient to compliant to voice rest, so that the patient know what is vocal hygiene, and they will stick to vocal hygiene after the surgery, and they would know how they were going to resume vocalization after 5 days of voice rest after surgery. And by sending the patient to SLP, which is a speech language pathologist, and the patient would be compliant to this, adherence to voice rest, vocal hygiene, and so on, that would also optimize the healing process of your surgery, of the surgical site, and that would minimize scarring, so then you have a better outcome. So specific management of benign vocal Follicion is quite straightforward. You have lesion in the vocal fold. If you see nodules, the treatment is non-surgical first, not surgery. Yeah, you have to try medical treatment first. You do surgery if the nodules are recalcitrant. It does not regress with non-surgical treatment like voice therapy, treatment of LPR, treatment of allergic rhinitis, and vocal hygiene. For polyp and cyst, the primary treatment is surgery first, right? However, in tiny polyp, there is still role of non-surgical treatment first, which I'm going to show after this. Right, this is an example. This is larynx of a patient, a singer. The problem is she can't reach certain notes and her voice tends to break. And on history taking, the patient have significant symptoms of allergic rhinitis. So have a look at the larynx. Can you see the pathology? The pathology is at the mid part of the vocal fold, okay, which is at the free edge. Can you see that? It is bilateral and symmetrical. This is a typical findings or appearance of vocal fold nodules. So vocal fold nodule, normally it is bilateral and symmetrical, unlike cyst and polyp. Okay, can you see that on eye scan? You can see the nodules better. And have a look at the stroboscopic examination. Now you can appreciate that when she phonates, the closure is not a normal complete closure. It is an hourglass closure where the contact point is at the nodule side. Yeah, there's incomplete closure. Again, yeah, I'm going to play the stroboscopy for you to appreciate. Now the hourglass closure is more marked when the patient do high pitch. So no wonder she can't go high notes, yeah, because the vocal fold, the mucosal wave become asymmetry on the high pitch. So she was treated with allergic rhinitis treatment and sent for voice therapy to SLP and educate her on vocal hygiene. And this is 1 month after the treatment. So hope you can appreciate that on a low note on normal conversation, she has now complete closure and good mucosal wave, but she still have a small bump can be seen, very tiny one on high note, but the mucosal wave become more symmetrical. So this is not complete yet, the treatment. So you have to advise the patient she needs to continue treatment with allergic rhinitis treatment, continue practicing vocal hygiene, and tell her she needs to really learn, yeah, go to vocal classes not to cause more trauma to the vocal fold. So that is on vocal nodules. What about vocal cyst? Vocal cyst, that the primary treatment is surgery. Okay, what do you call that? Speech voice therapy would then reduce the size of vocal fold cyst. Okay, because you have to go back. What is the cause, yeah, of vocal fold cyst? Vocal fold cyst, if you read, there are a few theories. Okay, mainly because one of the theories is there is phonotrauma, inflammation, blockage of the small salivary glands under the mucosa, and then because of that, there's accumulation of fluid in a sac because of the blockage of the small salivary gland, minor salivary glands. And that is one of the theories. So in a vocal fold cyst, definitely the treatment is surgery. And vocal fold cysts have highest risk of vocal fold scar compared to nodules and polyp, because when during the surgery, you have a tendency of losing the dissection plane because it tends to rupture. And because of this, there is risk of incomplete removal. So not only the patient may have scarring, the patient also would have a recurrence because there is incomplete removal of the cyst. And for the treatment, doing surgery in vocal fold cyst, you need to use micro instruments and you need a high magnification to make sure that the surgery is with precision technique. You can appreciate the layer of the vocal fold, and there is role of hydrodissection, which I'm going to show after this, which this one would minimize the risk of injury to the vocal ligament. And also another surgical technique, medial microflap, is recommended in doing surgery on the vocal fold. Right. So when I say micro instruments, I would say that the choice of size of micro instrument is very important. Okay. For example, this is laryngeal hook. You can see there are two sizes. One is about half of centimeter. Another one is about 2 millimeter. And sickle knife. This is Bucheya forceps, which is very important when you do surgery. You would want to use this, which the size is 2 millimeter rather than this, which is about 0.4 centimeter or 4 millimeter size. Okay. Crocodile forceps, scissors. So what I want to emphasize here is size matters. You need to choose the small microlaryngeal instruments when you do this kind of surgery. And you also need a different types of laryngoscope to ensure good laryngeal exposure, because some patients with small chin, retrognathia, short neck, okay, would have difficulty in exposing. You would have difficulty in exposing the larynx. So without good laryngeal exposure, you may not be able to do the surgery precisely, and the patient may end up with trauma on the vocal fold. And another thing which is important when doing the surgery is you need to rest your arm. You need a chair that has a resting arm here to put your elbow, so that when you are doing the surgery, you're not moving the elbow, but you're just moving your finger and wrist, right? Because when you are doing surgery under high magnification, just a little bit of movement, okay, will be seen under the microscope. Okay, so this is a laryngoscope with suspension, laryngeal suspension. So now we're going to talk about technique of excision, right? So there are two types of microflap being described in the book. One is lateral microflap, another one is medial microflap. In lateral microflap, the incision is made way lateral from the lesions, so that when you make the incision, you would see the ligament first, like this. You would see the ligament and you dissect the mucosa on the ligament until you see the lesion. And then you dissect the lesion of the ligament. So the actual reason of this surgical technique is to prevent injury to the vocal ligament, because you see the vocal ligament, you would want to avoid injury, so you dissect carefully. However, during dissection on the vocal ligament, there is chance that you would stimulate fibroblasts on the vocal ligament, the deep and intermediate. When you stimulate this, although you don't injure, but you keep on dissecting on it, it would cause formation of collagen, deposition. A lot of collagen will cause scar. So nowadays, this is not recommended way of raising flap. So what is recommended is by doing medial microflap. Yeah, medial microflap, you make the incision on the lesion itself. Okay, so that's when you make the incision, when you open up, rather than you see the ligament, you would see the lesion first. and then you dissect the lesion of the vocal ligament. And if the lesion is small, the cyst is small, you can cut the cyst together with the mucosa like that, and whatever leftover mucosa, you put it back. Okay. However, in certain cases, you may be able to remove the cyst totally without cutting off the flap that you have raised, which I'm going to show a video of this. So this is a patient who have vocal cyst. Can you appreciate the cyst? Please be reminded about nodules and cysts. Yeah? Nodules, which I've shown in the previous slide, there are bilateral and symmetrical, whereas cysts normally unilateral. It can be bilateral, but if it is bilateral, it wouldn't be symmetrical. It would be at different level, maybe one here, another one more anterior. Okay. Right, and one would be bigger than the other one. It wouldn't be bilateral at the same level and symmetrical. So this is a cyst on a right vocal fold. So you would appreciate that. Sorry. You would appreciate that there is a roundish, let me, hang on, yeah. I want to mute the sound so that I can explain. Okay. All right. So I want you to appreciate there is kind of sac under the mucosa. So this is typical of a cyst. And the patient also have sulcus on the opposite side. And that is asymmetrical mucosal wave and hourglass type of closure. And the patient cannot sustain the voice too long because there is glottic insufficiency caused by the cyst. Okay, so just now I mentioned about hydrodissection, which by infusing normal saline or 1 in 10,000 adrenaline into the lamina propria would help in preventing injury to the vocal ligament. Okay, because you elevate the mucosa from the ligament. So I use this butterfly needle, a modified butterfly needle. And here you can see that the needle goes just next to the cyst, and see how much the hydrodissection will elevate cyst from the vocal ligament. Can you see that? It is elevated from the vocal ligament. And then you use a sickle knife to make incision on the mucosa without puncturing the cyst. So this is what I meant by medial microflap. You don't make the flap lateral. If you make lateral, you make incision, you would see the vocal ligament first. But here, when you make incision, what you see is the cyst. Okay, can you see that? The cyst. So you raise the flap medial to the cyst using laryngeal elevator. Then this is a small Bucheyev forceps, 2 mm. Hold the mucosa that you have elevated, the medial mucosal flap that you have elevated. Use a blunt instrument like laryngeal elevator to dissect the cyst from the vocal ligament and from the attachment, posterior and anterior. There's a fibrous attachment over there. And then when you have done that, you are lucky if the cyst does not rupture. This is an epidermoid cyst. So for residents, you need to read. There are 2 types of cysts, epidermoid cyst and mucus retention cyst. Please read about the theory, development of the cyst, and what are the differences between the two with regards to the content. So you hold the cyst with Bucheyev forceps, use curved micro scissors and cut the thing off, the stalk off. And now you can see that I didn't cut the mucosa at all, like how it was described in the book, because I managed to remove the cyst without rupturing it, and this would be very nice outcome, because you want the mucosa to close, to be draped on without any raw area exposed. And after this is the sulcus. 3 months after surgery, okay, you can see that there is no more cyst. And on stroboscopic examination, okay, you can see symmetrical mucosal wave, good glottal closure, okay, and the patient happy with the voice. So this is one technique. You can watch this video on my YouTube channel. What about if you get this kind of cyst? This is mucus retention cyst. Yeah, normally it is glistening, clear color, but it is rounded. And this patient has kept the cyst over there for more than for about 10 years. So you can hear that the voice is rough. Yeah, I would say overall dysphonia grade 3, and there is some breathiness component as well, because obviously this kind of cyst would impede the glottal closure. Thus, the patient would have glottal insufficiency as well. So hope you can appreciate, yeah, that there's no complete closure. The mucosal waves are asymmetrical and aperiodic. So when we do surgery in this kind of case, where the cyst is big and it is wrapping around superior, free edge and inferior part of the vocal fold, chance of rupturing it and chance of getting vocal cord scar is high. This is the patient, okay. The cyst ruptured during the surgery. I have to remove the cyst together with the mucosa, so that I wouldn't leave any cyst behind to prevent recurrence. And this is the endolaryngel findings. So this is a slow motion. I want to show that there is no non-vibrating segment. Everything is vibrating, but you can see that there is probably slight scarring over here because the amplitude is slightly reduced compared to the opposite side. Okay, and this is the patient's voice.
Sorry, Prof, maybe it's a mute, Prof.
Or is it mute?
Yeah, we can't hear the voice.
Okay. All right, did you hear the patient's voice, the previous one?
No, Prof, the previous one is also, we can't hear the voice.
Okay.
Bismillahirrahmanirrahim. Semasa saya masih kecil, saya tinggal di kampung bersama nenek. Ayah dan mak tinggal di bandar. Abang dan adik.
Can you hear the voice?
Yes, Prof.
Okay, so the voice is hoarse, and after surgery, this is his voice.
Semasa saya masih kecil, saya tinggal di kampung bersama nenek. Ayah dan mak tinggal di bandar. Abang dan adik saya tinggal di bandar.
So although there is more scarring, the voice is good and patient happy with it. So the point here is you have to, for residents, when you do surgery on the vocal fold, you have to respect the layers. You have to prevent formation of scar as much as possible. And that's why you need a high magnification. You need a good surgical technique. Yeah, hydrodissection would help, and medial microflap would help. Right. Yeah. Post-operatively, to optimize healing and to prevent scarring, post-operative care is very important. You need to tell the patient to rest voice. Normally, I tell them to rest their voice for 5 days, and those patients who are high professional voice users, they use the voice a lot. I give a longer medical certificate so that they wouldn't fully use the voice for certain duration. And I normally give proton pump inhibitor as a prophylaxis to prevent any accidents of acid reflux to the surgical area, and re-emphasize the patient on vocal hygiene. So now, any role of surgical, non-surgical treatment? Just now we talked about cyst, now we talk about polyp. Okay, polyp, the mainstay of treatment is still surgery, but then the question, is there any role of non-surgical treatment? The answer is yes, for a tiny polyp. I give you an example. A patient who have allergic rhinitis, a chronic smoker, use voice a lot at work, love to drink coffee, and have been taking unhealthy diet. This is his larynx on the right hand side at presentation. You can see that the patient has a small polyp. So what I want to, for residents, I hope you can appreciate the difference between polyp and cyst. Okay, polyp by definition is a protrusion of edematous mucosa, whereas the pathogenesis of cyst is blockage of minor salivary glands or inclusion theory. So the lesion is underneath the mucosa within the superficial lamina propria, whereas vocal polyp is on the epithelium itself, on the mucosa. So therefore, you would see abnormal mucosa. It can be whitish, it can be telangiectatic with the big blood vessels, and sometimes they may have hemorrhagic polyp. Okay, and it is normally unilateral. In this patient, you look, there's another lesion opposite side. This is not polyp, but this is what we call a reactive lesion due to trauma rubbing of a polyp to the opposite mucosa during phonation. And you can appreciate that the patient also have a thick endolaryngeal mucus due to reflux, due to allergic rhinitis. So the patient was treated with allergic rhinitis treatment. Tell him to stick on vocal hygiene, stop coffee for a while, and then 3 weeks after treatment, when reviewed, the polyp is already smaller in size, right? Smaller in size, and the reactive lesion also smaller in size. And upon review, months after that, everything has resolved and the patient does not need any surgical treatment. What about big vocal polyps? Big vocal polyps are unlikely to resolve with medical treatment. Then you would need to do surgery. So is there any role of microflap? Any role of hydrodissection? It depends on the size of the polyp and the characteristics of the polyp. Okay, let us see this example. A tiny small polyp. The size is, I think, the Bucheya size is about 2 millimeter. So the polyp is probably about 4 millimeter size, 3 to 4 millimeter size. And you can see that it is pedunculated with thin neck. And you can see clearly okay. I don't know why the video is not working. Okay, you can see that it is pedunculated. Okay, can you see this video like this?
Yes, Prof.
Okay, so you can see that it is pedunculated with a thin neck. So in this kind of case, hydrodissection is not necessary because the hydrodissection may what do you call that, hide or may cause confusion which is normal and which is abnormal. So when you have this kind of case, you just cut using scissors. You don't have to do microflap. You need to remove this all together with all the abnormal mucosa. And you can see that there is minimal raw area, and you even can put it back together. So this is a simple case of a small tiny polyp with a pedunculated thin neck. Okay. Whereas you have another type of polyp. Okay, another type of polyp which is pedunculated as well, but it is rounded, and your instrument would have difficulty to grasp because it's firm and rounded. So that you can do hydrodissection like that. Elevate the epithelium from the vocal ligament, and then you use a sickle knife. Use a sickle knife to make an incision over there. Okay, after you make the incision, you grasp the mucosa that you have incised with Wucheya forceps, and then you use scissors, upturned scissors, to cut the mucosa over here. Okay, so I don't have to finish the video. So that is when you still need to make a small flap, but then the difference between polyp and cyst, the polyp, definitely you have to remove the abnormal mucosa with the whole thing together because all those is abnormal. Okay, so after surgery, you would want to have this kind of results where the mucosal wave, this is the same patient which have polyp, just on the slide that I've shown just now, the pedunculated but firm polyp. You want to have a symmetrical symmetrical mucosal wave without any non-vibrating segment. There is something wrong. I think Arfiza's problem with laptop has infected my laptop as well. Okay, now the video is working. From Sumatra, it comes here through the cable. Okay, so you can see the mucosal wave is symmetrical and there is no non-vibrating segment, and the patient happy with the voice. Okay, so now someone who have this kind of polyp.
Sekarang Nancy kata panjang-panjang.
So this is hemorrhagic polyp. Okay, there is no as such hemorrhagic cyst. Okay, the one that hemorrhage is normally polyp because polyp have telangiectatic vessels, varix, ectatic vessels on it, abnormal vessel because of edema, inflammation, and so on the mucosa. Yeah, you have to remember the pathogenesis of polyp. So in this kind of broad base, without pedunculated lesion, you need to raise a flap. Okay, because chance of you injuring the vocal ligament is high. Right, so I give an example, a big polyp which would not resolve with medical treatment and you need to do surgery. And this kind of patient, you need to raise a flap. You need to do hydrodissection. This is a 40-year-old man who is a chronic smoker and a contractor. Use voice a lot. Okay, here I'm going to show you the surgery, yeah, endolanger microsurgery. This is direct under direct laryngoscopic view. We are doing endolaryngal microsurgery. You can see a huge polyp. Okay, so and then incision is made at the junction between abnormal mucosa and normal mucosa, and a flap is raised, and you can see gelatinous material in that. So this gelatinous material have to come out. This is not a cyst. This is a gelatinous material. Okay, and remove it together with the abnormal mucosa, and then put whatever normal mucosa back together. And you would, at 5 months, you would want this kind of results. Okay, and this is the stroboscopic findings. Okay, so you want a symmetrical mucosal wave. However, there is some redness. Probably there's a little tiny scarring over there, but you know, there's no non-vibrating segment. Everything is good. The patient is happy with the voice. Now, we talk about benign vocal Follicions already. I'm going to move on another topic on neurologic voices. This is just an overview, so I touch here and there. The details you have to read. Yeah, for neurologic voice disorder, I'm going to focus on spasmodic dysphonia. As I have mentioned in the previous slide, in neurological voice disorder, what are the diagnoses categorized under this? Spasmodic dysphonia, vocal cord palsy, Parkinson, vocal tremor, myasthenia gravis, and so on. Vocal cord palsy I'm not going to cover in this lecture. Parkinson is not that common. Myasthenia gravis is not that common. For neurological voice disorder, other than unilateral vocal fold paralysis, spasmodic dysphonia is the common one. So for spasmodic dysphonia, they are divided into adductor and abductor, and some patient may have mixed, and some patient may have vocal cord tremor together with this spasmodic dysphonia. And it is a vocal dystonia of the intrinsic laryngeal muscle without known cause. Yeah, there's people still can't prove, although there are theories like they said there's genetic issues, and they said there is some increase in dopamine activities in the basal ganglia. Right, so in ADD, adductor spasmodic dysphonia, the voice is normally strangulated and jerky, yeah, because there's spasm of adductor muscles during phonation. Yeah? So therefore, the aim of treatment in adductor spasmodic dysphonia is to reduce the glottic tightness. So that's the patient from like this, my name is Marina, become my name is Marina. Okay, so you want it to make it smooth. Okay, so how to reduce the glottal tightness? You can do give oral you can give medications. Okay, voice therapy and oral medications are proven to be non-effective in adductor spasmodic dysphonia. You can send, but then it is not effective. Voice therapy may help to reduce a little bit of muscle tension dysphonia, but not the adductor spasmodic dysphonia. The mainstay of treatment currently for adductor spasmodic dysphonia is by injecting botulinum toxin A into the paraglottic space, which contain the thyroarytenoid and lateral cricoarytenoid muscles. These two muscles are strong adductors of the vocal folds during phonation. And what about surgical treatments? These are the options of surgical treatment, can be divided into open and endolanger approach. For open, for laryngeal framework surgery, it is type 2 thyroplasty. And another one is selective laryngeal adductor denervation and reinnervation. And for endolaryngeal approach, people have described thyroarytenoid myectomy, and some people do together thyroarytenoid myectomy as well as neurectomy endolaryngally. So these are the treatment being described in the literature. Now we're going to focus on botulinum toxin. What does this botulinum toxin injection do? It is derived from Clostridium botulinum, from a bacteria. And there are different types of botulinum toxin from A through E, but the one that we used for spasmodic dysphonia are A or B. Okay, and the most commonly used is A, which is commercially available, such as Botox, Dysport, and Xiomi. Okay, and what does this botulinum toxin do? It prevents release of acetylcholine. How does it prevent the release of acetylcholine? The botulinum toxin, which go into the synapse. This is neuromuscular junction. Okay, this is the end of the nerve, right? And this is the muscle. So this is a neuromuscular junction. So when the botulinum toxin enter the synapse, the end of the nerve, it snap the light chain. Okay, it snap the light chain, which is called SNAP 25 protein. This one here, 25 protein. Okay, so when the botulinum toxin snap or snare, cut this light chain, it prevents adhesion of these molecules that contain acetylcholine onto the surface. So when there is no fusion of this acetylcholine to this surface, there wouldn't be any release of acetylcholine that would help in transmission of nerve impulse to the muscle. So therefore, the muscle is weakened because of this. So the effect of botulinum toxin is not immediate. Okay, on average, day 3, the voice become ready. Why become ready? Because when we inject the adductor muscle, it weaken it. So when we weaken it, we are kind of inducing vocal cord adductor paralysis or paresis. So there would be some phonatory gap. The glottal tightness will be reduced. And in severe cases, they may have aspiration. So therefore, you have to alter the dose afterwards. Advise the patient at day 3, when your voice becomes soft, you have to drink slowly. Do chin tuck maneuver to minimize aspiration of fluid. And this readiness of voice may last up to 2 to 4 weeks. Okay, what we want is only 2 weeks. If it goes up to 4 weeks, the next time injection, we have to reduce the dose. All right, and the patient normally would need to repeat the injection at 3 months after, because the effect is not permanent. So Dysport or Botox, you can use either one. Okay, in my center, we use Botox more than Dysport. Okay, the doses also range. Okay, the range of doses, there are no specific dose. Okay, normally people start with 5 units, all right? If you inject bilateral, you would inject a smaller dose in each side rather than you don't inject 5 unit, so you would inject 2 units on each vocal fold. So if, let's say, when you are injecting the botulinum toxin, with time, the patient feel like the dose is inadequate and you keep on having to increase the dose from time to time, it may indicate that the patient has developed resistance towards the botulinum toxin, because this is from bacteria, the body can develop antibody. So once they develop resistance, the Botox may eventually wouldn't work. And this time you may think about doing surgery when it is not working anymore. If the dose, you tend to decrease the dose with time. Let's say you start with 5 units, and after like 1 year, unit is too much, the voice is too breathy, you have to reduce to 2.5, and you have to reduce furthermore. It may indicate that the patient has developed some chronic denervation of the muscle, and it may be irreversible. Thus, you have to reduce the dose. So whether to inject unilateral, bilateral based on surgeon's preference, and be minded that if you inject bilateral, you have to inject smaller dose because you do not want the patient's voice to be so breathy until the patient get aspirations. Okay, this is what we use botulinum toxin. Right, the technique of injection, you can do it percutaneously under local anesthesia, or you can do it under general anesthesia. But general anesthesia is not recommended because the long needle, we have issue to determine how much you can inject, because if you are injecting 0.1 cc, which is equivalent about 5 units of Botox, the Botox will just remain in the long needle, and you have to push with normal saline that would further dilute. So it is not that recommended. So normally we use under local percutaneous. You can do either transthyroid, or transcricothyroid. And another way of doing it is by using laryngeal EMG to enhance the accuracy. So this is the way we can do, if we do percutaneous, doing double bend needle through the neck. Okay, this is paraglottic space. So when your needle enter the paraglottic space, so the botulinum toxin will be infused in this muscle. What are the muscles in the paraglottic space? Thyroarytenoid as well as lateral cricoarytenoid at the back here. Right. Another option of where you can inject the botulinum toxin A other than the paraglottic space is by injecting the false cord. Right. I'm going to show a video injection of the false cord. So here the larynx is already anesthetized, and okay, so I want you to appreciate the needle enter the petiole of the epiglottis, and then the needle is directed to the false cord, and you inject Botox at the false cord. Okay. Right. So why we inject at the false cord? Because some patients, they don't like the too breathy voice. So by injecting the false cord, the botulinum toxin will diffuse to the paraglottic space slowly rather than abruptly, and the breathiness will be less. Okay. So this is one of doing this. Okay. Another way of injecting is by using laryngeal electromyography.
To the cricothyroid space. This is the potential space lah ya. Lepas tu kita rasa where the inferior border of the thyroid cartilage. So and direct it towards the paraglottic space. Okay. Okay. Cuba cakap E.
So I hope you can appreciate when I tell the patient to say E, you can hear the raindrops sound. So that is the sound from the laryngeal EMG machine showing that the needle is in the paraglottic space in the adductor muscle. Because the E, the vocal cords are adducted. So therefore, the adductor muscles are contracting and giving the signals on the laryngeal EMG. So when you are sure that the needle is already in the muscle, okay, then you inject the botulinum toxin A, which you can see syringe over here attached to the needle. So that's the signal.
Okay, jangan telan ya. Cuba cakap E.
Okay, so the advantage of using laryngeal EMG, you don't have to give anesthesia. Okay, for example, into the larynx, you have seen just now how we did percutaneous. The larynx have to be anesthetized, or else when the needle enter the larynx, the patient would start coughing. Okay, you wouldn't be able to do the procedure. So it doesn't need laryngeal gargle. It doesn't need, and it would be more comfortable for the patient, and it's accurate because the EMG direct us where the muscle is. The disadvantage is you need extra instruments. You need neurologists to be there. You need to book a neuro lab to do this procedure. Neuro laboratory where the machine is. Okay, so Botox is the mainstay of treatment for adductor spasmodic dysphonia as well as abductor. For abductor spasmodic dysphonia, the botulinum toxin is not injected into the TA and LCA. The Botox is injected into the posterior cricoarytenoid muscle, which is at the back of the larynx. Difficult to reach it, but something that you need to practice doing it. It's difficult and very uncomfortable for the patient. Good voice outcomes if you inject for adductor spasmodic dysphonia, but then in patients who have concomitant abductor and vocal tremor, good voice outcome is difficult to achieve. Remember I mentioned that some patients with adductor ADD spasmodic dysphonia, they may have abductor ABD as well and vocal tremor. If they have all these three in one patient, good voice outcome is difficult to achieve. And some patient may have a severe muscle tension dysphonia. A little bit on surgery. Surgery is reserved for non-effective cases. Patient who tired, doctor, I'm so tired of this injection every 3 months. Can you do operation? And you think about doing operation. Or the patient has developed resistance. Remember, I told you about resistance. Or sometimes some surgeons, they prefer doing operation than inject with botulinum toxin. So I'm going to show a typical case of a spasmodic dysphonia. This is her voice before the injection.
Semasa saya masih kecil, saya tinggal di kampung bersama nenek. Ayah dan mak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan setiap minggu saya dan nenek pergi ke rumah ayah. Jika kami tidak ke bandar, ayah, mak, abang.
So I want you to appreciate giving lecture during Ramadan is hard because you cannot drink water, cannot practice vocal hygiene. Okay, I hope you can appreciate her voice is strangulated and jerky. Okay, this is because there's a spasm of adduction during phonation. This is the voice of the patient after botulinum toxin A injection.
Semasa saya masih kecil, saya tinggal di kampung bersama nenek. Ayah dan mak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan mak.
So, you can hear that the voice is smooth. There's no strangulation, but it is softer because you have weakened one side of the adductor muscle. Okay, so then the voice is softer but smooth. And I'm going to show you a severe case of adductor spasmodic dysphonia.
Semasa saya masih kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar.
Okay, so that is her voice, strangulated and jerky.
Say E for me.
Semasa saya
And this is her voice after like 1 week after injection.
Semasa saya masih kecil, saya tinggal di kampung bersama nenek. Ayah dan mak tinggal di bandar. Abang dan adik.
So you hear her voice is breathy, right? Breathy and soft. This is because there is glottal gap. Okay, see the larynx.
Alright, Datin, can you say E?
So can you appreciate there is a glottal gap? Okay, it's because the adduction is weakened. There is no complete closure, and there's a glottal gap. This is side effect of the Botox. This is when you have to tell the patient, drink slowly, do chin tuck maneuver. But this problem wouldn't persist. It would resolve by 2 or 3 weeks. This is the patient's voice 3 weeks after injection.
Masa saya kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah.
And after 3 months, the strangulated voice may occur, and you have to re-inject. So if you see that when you inject, the voice is so hoarse, so breathy, the next injection you would want to reduce the dose. Yeah.
Masa saya
So a little bit on surgical treatment. Okay, this is selective laryngeal adductor denervation and a re-innervation. Okay, this is another topic. I think I'm not going to cover here. Please read up. This is an option of treatment. Those days, people do just transection of the nerve here, but they found that it is effective only certain duration, and this problem tend to recur. This is because the transected recurrent laryngeal nerve tend to regenerate. So when regenerate, re-innervation of the vocalist muscle, so the spasmodic voice, the strangulated voice recur. So that's why they have stopped just transecting the recurrent laryngeal nerve. They describe selective laryngeal adductor denervation and re-innervation. Okay, this is some concept that please read for you to understand. Another surgical treatment is by doing type 2 thyroplasty. Yes, described by Ishiki. And Ishiki have developed also a titanium implant to keep the vocal, to keep the thyroid lamina apart. Yeah, here in the middle, they put the titanium implant in the middle to keep the vocal cord apart, so that there would be reduced in glottal tightness during phonation. Okay, so called lateralization. Not too much until it causes aspiration, just to reduce slightly the glottal tightness by doing lateralization. Lateralize the lamina propria. Okay, so you want to read more about this type 2 thyroplasty. Now, I'm going to move on to the next one. I think the last one, functional dysphonia. We talk about benign vocal Follicions. We talk about neurological voice disorder. Now we're going to talk about functional dysphonia. So functional dysphonia is a condition of change in voice quality with the absence of structural abnormality or neurogenic dysfunction. There's no immobility, there's no paralysis, the structure is all normal, but yet the patient's voice is hoarse, dysphonic. This is due to imbalance of tension of muscle that control the voice production. The larynx is like locked in abnormal posturing, and there is discoordination between the intrinsic muscle and extrinsic muscle of the larynx during voice production. So it is to diagnose functional disorder, it is a diagnosis by exclusion. You need to get thorough history taking, do voice assessment, and do laryngoscopic examination. Laryngoscopy is vital, not to diagnose what type of functional dysphonia is, but to rule out structural or neurological issues, especially in a subtle structural issues like sulcus, small lesions on the vocal fold, okay, which may not be seen on a normal laryngoscopy. So it is a diagnosis. It's more of excluding structural issues, excluding neurological issues, and you may think about functional dysphonia. And the presentation may be diverse. It can be sudden or gradual. Okay, and these are the synonymous terminology being used to describe functional dysphonia, like psychogenic dysphonia, psychosomatic, hysterical, conversion, and so on. And for muscle tension dysphonia, primary muscle tension dysphonia is included under functional dysphonia. Okay. However, secondary muscle tension dysphonia is not under functional. Secondary muscle dysphonia is common in patients who have issues at the glottic region, like vocal cord palsy, like lesions, polyps, cysts. So the muscle tension dysphonia is a compensation mechanism to close the glottic gap. So in primary muscle tension dysphonia, it commonly occurs in people who have high voice demand. They continue producing voice in a stressed condition, in a tired condition, without practicing vocal hygiene. So there is chronic pathological state of hypercontraction of the paralaryngeal and suprahiatal muscle. The extrinsic muscle become tight. And the treatment, it tends to respond effectively to voice therapy, tell patient about vocal hygiene, do some relaxation techniques which can be taught by our speech language pathology, and this treatment would be effective in primary muscle tension dysphonia. I give an example, a preacher who preach a lot, give religious talk a lot, and he described he feels that his voice become strangulated during speech, during the ceramah, during a religious talk. So I want you to appreciate that when the vocal cords are phonating or adducting, the false cord is squeezed to the midline and impinged on the true cord. This is the reason why he feels strangulated during his talks. Okay. So then this patient is sent for voice therapy because we have ruled out any lesions on the vocal fold. Okay, and we think that this is primary muscle tension dysphonia, and you see this difference. This is after voice therapy. The patient is taught about when you speak, you have to correct your posture, you have to smile, you have to use your face whenever you speak rather than using your neck whenever you speak. So I want you to appreciate how the vocal folds are phonating when the patient is using the voice correctly. They describe it as suara leher, and when the patient is suara leher is wrong, using neck is wrong, and this is the correct one. So let's have a look.
Sekarang Ustaz buat E panjang-panjang dengan suara leher. 1, 2, 3.
Can you see that the voice is hoarse, and then you can see that the supraglottis region is squeezing in. Okay, and we let the patient see this so that the patient have visual feedback. Oh, if I do this, that is how my larynx look like, and this is a correct one.
Sekarang Ustaz buat suara E panjang-panjang dengan suara muka, suara tinggi. 1, 2, 3.
You can appreciate the larynx open. You can see the vocal cords more, the supraglottic structure more relaxed, and the patient's voice is not hoarse. Okay, so now I give an example, hysterical voice disorder. Okay, now we're going to talk about the treatment. Okay, for primary muscle tension dysphonia, patient has active role. The patient needs to know, well, this is the way I should talk. This is the way I should do. This is my posture. We give a visual feedback. But then for another type of functional voice disorder, hysterical type, the patient does not have an active role. The speech language pathologists have to unlock the larynx, okay, by doing digital manipulation, okay, and there are some maneuver like tell the patient to cry, tell the patient to cough, and try to produce voice to unlock the abnormal position of the larynx. I give an example. A patient who is a young female described her voice sudden onset of hoarseness after an emotional event after watching K-drama. I think all of you like to watch K-drama. Maybe not all, many of you. This is her voice.
Okay.
Semasa saya kecil, saya tinggal di kampung bersama nenek. Ayah dan mak tinggal di bandar. Abang
Someone when listen to her voice may think, oh, maybe she has a vocal cord palsy because the voice sounds breathy. But then those people who listen to breathy voice a lot, when you hear this voice, you know that she is actually whispering. Semasa saya masih kecil, saya tinggal. She is whispering, okay? And to confirm that, you ask her to do cough. If she can produce normal cough, effective cough, it means that she doesn't have any glottic insufficiency. There is no vocal cord palsy, but yet she produced this kind of voice. So this is her larynx.
Nafas. Macam tu lah. Dah abdomen.
So she is not producing her voice correctly. There's no vibration at all, which is impossible when you have normal function, mobility of the vocal fold, and there is no structural issues. Then she is referred to speech language pathologist, and at the same time also I did some laryngeal manual therapy and tell the patient to cough and phonate.
Saya tak mau nak atas. Kuat turun.
saya.
Lagi.
Saya.
Yes. Lagi turun.
You see that she can produce. Saya rather than saya masih kecil. So you need to unlock it. You need to rock. You need to do some laryngeal manual therapy. Tell the patient to cough and produce voice. So she realized, oh, actually she has voice. And you have to unlock the condition. And this is her voice 2 weeks after.
Semasa saya kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar.
She has beautiful voice.
Semasa saya
And this is her larynx. Now there's mucosal wave. She's producing her voice a lot. This is what we call hysterical dysphonia, and this is categorized under functional voice disorder. There is no structural issues. I don't have to play this. Okay, another one is a condition. A condition whereby which commonly occur in male teenagers whenever they reach puberty. You listen to this teenager boy's voice. Oh my God, what's happening?
Semasa saya masih kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar.
If you don't look at him, you may think that it's a female, but actually he's a boy. And when you examine the larynx, there's nothing wrong. Everything is good, mobile, okay? Mucosal wave is good. Okay, and then this is a diagnosis of puberphonia. Okay, another type of functional voice disorder. And after voice therapy, this is his voice.
Semasa saya kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar, abang dan adik.
Okay, So I hope you grab the concept of functional voice disorder. Right.
Nama saya
Oh.
Misha.
Oh, this is bonus. I just added this. We have done activities to celebrate World Voice Day, and we have done laryngeal karaoke with our popular singers in Malaysia, and one of the singers is Misha Omar. I don't know whether she is popular in Indonesia or not. She has sang many hit songs. Okay, so this is one of a hit song. This is me doing endoscopy, stroboscopy while she's singing. Just enjoy her voice today.
Nama saya Misha Omar dan saya akan menyanyikan lagu Sampai Bila.
Okey.
Oh, dia macam nak terlain Leo tu, dia macam ada rasa sikit. Okey.
Rasa apa Kak Min?
Rasa ada sesuatu lah. Okay. Dalam rindu yang tak bererti apalagi, biarkan aku kini sendiri. Oh, pergilah dengan dia yang kau cinta, dan tak perlu kau di sini mengungkit kesilapan. Sampai bila harus ku bertanya, firasat hatimu yang terus membisu segala dendamku kini telah menjadi bebanan jiwa. Saat kau mencari pengganti, padamu aku hanya kaca yang tak berharga, pudar seri kosong kelam tak bermakna.
Okay, so that is her beautiful voice. Why I want, so by the way, the song is the title is Sampai Bila. Why I show this, people ask me, how come she can sing with the scope in the throat? So there are two reasons. Number one, the patient is calm, not that anxious. And number two, very important thing is the technique of you doing endoscope. Okay, so for residents, you need to polish up the way you do endoscope. And now, if you go in international conferences, the recommendation is when you examine the larynx, you have to go as near as possible so that you can appreciate many normal or abnormal structures. So when you have good technique, the patient would be comfortable and you would get the findings that you want. So in conclusion, management of voice disorder would depend on the diagnosis, whether it's structural, neurological, or functional. And of course, you need a teamwork with SLP. For structural lesions, the mainstay of treatment is precision surgery, except for nodules. For nodules, the mainstay of treatment is medical treatment first. However, in recalcitrant nodules, you still have to do surgery, but you need to tell the patient it will come back if you don't stick to vocal hygiene. And you also have to treat the underlying factors. Voice therapy also important. In a neurological type of voice disorder, like in this lecture, I focus on adductor spasmodic dysphonia. The mainstay of treatment is botulinum toxin injection. For functional voice disorder, the mainstay of treatment is voice therapy. Okay, and you have to emphasize by the time the patient come to you, every time the patient come to you, you have to keep on re-emphasize on vocal hygiene. Have a pamphlet in your clinic, give to the patients, and tell the patient about healthy lifestyle. So with that, thank you so much for your kind attention.
Thank you, Prof. Maybe we can proceed to our case discussion, Prof. Maybe my first case is about Idiopathic.
Before that, before they forget about my slides,
Yeah.
anyone would like to ask question?
Okay, Prof. Okay,
or do-
maybe anyone want to
Yeah.
ask the question to the.
Yeah. Do you think that the content of the lecture is too high for the residents?
No, I think it's okay, Prof. And they should know.
Okay. So any questions before we move on to discussion of cases?
Any question?
I would like to
Interested?
ask a question, Doctor and Prof.
Okay.
So during your lecture, you mentioned that the big lesions is not effective for voice therapy. So how would you determine the size of the lesions? Which one is better for a surgery and which one is better for medical management? Thank you, Prof.
Okay. This is about polyp, right?
Yes, Professor.
Okay. For polyp, you look at the size. I can't really tell you the measurements, but if you see that it is not broad based, it is pedunculated, and it is like there's just a few millimeter on the vocal fold, and the patient have marked active signs like a thick endolaryngel mucus and allergic rhinitis, you can try medical treatment. But big polyps, like I give you an example, those big polyps, okay, which giving voice therapy would not regret.
I would like to ask one question. You have mentioned about vocal hygiene, Prof.
Okay.
So could you explain detailedly about vocal hygiene? What should we educate patients about the vocal hygiene? Thank you, Prof.
Okay, welcome. So vocal hygiene, you can Google, you type vocal hygiene, there are loads of information in there. So basically, vocal hygiene is do's and don'ts. So the patient can keep the health, take care of the vocal health. Okay. Example, stop smoking, don't drink alcohol is vocal hygiene. Okay. Don't modify, take healthy diet, avoid all diet that will increase acid in the stomach, or any diet that can relax the sphincter, the gastroesophageal sphincter that can promote reflux. Okay. Another example in the vocal hygiene, drink plenty of water, especially when the patient is doing a lot of talking, because when the patient is doing talking, phonation, vibration of the vocal fold occur in a dry environment when the patient is not taking orally or fluid well. So there would be a lot of phonotrauma. Okay, so if the patient think plenty of water, the throat will be moisturized, there a lot of lubricants, so the vibration would occur in healthy environment. Okay. Manage the stress, sleep regularly, regular time, have enough sleep, because if the patient sleep late at night, don't manage the stress properly, there would chance of increased acid in the stomach that causes laryngopharyngeal reflux that disturb the vocal cords. Plus, the stress itself may cause functional voice disorder. Okay, so those are examples of content of vocal hygiene. The details you can read. Go to the internet, you Google vocal hygiene. Okay, the information is in there. All right.
Thank you, Prof.
Welcome. Any other question? Okay, if no question, Dr. Arfiza would like to share some cases.
Okay, Prof. Maybe I use one of my resident laptop, Prof, for the case. But actually, Prof, because these topics not mentioned about the unilateral focal paralysis, so the one case will be skipped for the next for the next lecture, Prof. Maybe I just want to show you one. I actually have many cases, but my laptop is, I don't know, 2 days ago can turn it on. So they said that it must be repaired for 2 or 3 days.
Oh my God. Okay.
Okay, Prof. Maybe can. This is the case, Prof. Actually, the same case that you have presented. I just showed the discuss about the next treatment that option that we will discuss with the patient. Next, so this is the patient, a female, 23 years old with the hoarseness for 2 years, worsening when distressed and fatigue when speaking too long. You can. Can you hear, Prof, the voice, the patient voice?
Nope, I cannot hear it. I cannot hear it.
Can you hear, Prof?
I still cannot hear it. I think the person who share the slide have to click on share sound. If you don't, you have to unshare the slide, share it again. Before you share, you click at the left bottom, share sound.
Merupakan masalah utama kesehatan masyarakat. Prevalensi yang tinggi akan meningkatkan morbiditas, mortalitas, biaya kesehatan, serta resiko keselamatan. Obstruktif sleep apnea merupakan sekitar 5%.
This is the laryngoscope. So we conclude that the patient has adductor spasmodic dysphonia, and we just give his botox injection for the patient. And after the 1 week after the botox injection,
dengan prevalensi yang tinggi
the patient's voice is better.
Mortalitas, biaya kesehatan serta resiko keselamatan.
But after 3 months, the patient has already have a recurrent adductor spasmodic dysphonia, and when we do an injection in the same doses, the patient has no improvement, and also after patient still has no improvement, but the voice is still have asthenia, but fatigue when speaking is reduced. After 3 months after that, Prof, the patient is coming back to our outpatient clinic, and we do an injection also. We increase the dose, but the dose, when we increase the dose, the patient is still have a little effect in the voice, but the fatigue when speaking is gone. But maybe in this patient, we should discuss about the next treatment that we treatment option that we can do to the patient. Maybe a surgery is one of the treatment option of this patient. How about your suggestion, Prof, about this patient?
Okay, how the injection delivered to the patient's larynx?
Local injection, we use the supraglottic approach, and we inject into the false vocal cord, Prof.
Okay, so the first time when the voice is smooth, okay, how much did you inject? Did you inject the false vocal cord or you inject the paraglottic space?
False vocal cord, Prof.
Oh, the first time also false vocal cord.
Yeah, also.
Okay, you never inject the thyroarytenoid.
Never, Prof. Maybe.
Okay. Okay, so how much did you inject?
I use in 5 micro unit, Prof.
Okay, so normally for false vocal cord injection, you need to identify what is the optimum dose first by injecting the paraglottic space. Okay, direct on the muscle. Let's say the patient get good voice with 5 unit. Okay, when you inject at the paraglottic space, then if you want to inject the false cord, you have to double the dose. So the dose in the false cord have to be higher than the dose if you inject the direct on the muscle. So for you to determine what is the double dose, you need to determine what is the optimum dose first by injecting the paraglottic space.
Okay, Prof. Thank you, Prof.
Okay.
Maybe our next case is unilateral paralysis vocal cord. Maybe in the next discussion, in the next lecture. I mean, maybe we can proceed to the Kahoot for the question for the residents and.
Yeah. How did you bend the needle, Fiza?
Actually, like you, Prof, double bend, Prof.
Oh, that's brilliant. That's brilliant. And you give intratracheal anesthesia as well?
Yeah, yes, Prof. From the oral, and the subglottic, subglottic, Prof. Oral and subglottic.
And some recommendation says that you may want to change the site of injection. Let's say this time you inject right side, the next time you inject left side. You alternate the site of injection if you are injecting just one side. But if you are injecting both sides, then you have to divide the dose. For example, if you are injecting the paraglottic space, 5 unit, you divide into 2. So 2.5, 2.5 on each paraglottic space. Similar to if you inject the false cord, if you're injecting both sides, you have to double the dose and you divide into 2.
Thank you, Prof.
Okay.
Okay, maybe.
So Kahoot, yeah? Kahoot.
Okay, maybe we can proceed because we have only 15 minutes for this lecture.
OSA merupakan masalah utama kesehatan masyarakat. Dengan prevalensi yang tinggi akan meningkatkan
Okay, we can proceed to the Kahoot. Maybe the presentation, the resident can join the Kahoot for the games. Yeah. questions game. Okay. Just give 1 minute. Please make sure that you join the Kahoot with your true name. Yeah, I don't know. It's and ENT in here. You can join with your full name because in the end there is a score that determine you have a high ranking or not. Okay, maybe the time is up. We just proceed to start the Kahoot. Okay, the more you answer quickly, you answer the question, the more the score that you get. So the right choice is not the only option. Okay, I just give regarding adductor spasmodic dysphonia, jerky and strangulated voice is the feature. True or false? And that's true. Okay, next. Maybe the first is Una. Wow, Una is the high score now, eh? Regarding adductor spasmodic dysphonia, botulinum toxin is injected to the THT-KL complex to weaken the adductor function, abduction function. True or false? Seconds left. And the answer is true. Next question. Still Una have. Okay, bilateral botulinum toxin injection into the paraglottic space is contraindicated. True or false? Five questions left. The answer is false. The highest score still Una. Wow. Okay, the next question. Transection of the recurrent laryngeal nerve is treatment option. True or false? Five seconds left. Okay, the answer is true. The next question, the score still Una. And next, thyroidenectomy is done via external approach. True or false? Five seconds left. Okay, the answer is false. His highest score still Una. Next. Puberponia is diagnosis in a female patient. True or false? 5 seconds left. The answer is false. Okay. Still Una and Giovanni for the second place. The presence of sulcus vocalis is common. True or false? Five seconds left. Okay, the answer is false. Next. Okay, still Una is in the first place. Okay. Laryngeal manual therapy is a treatment option. True or false? Okay, the answer is true. Okay. The next question. Functional voice disorder. This is due to disruption of coordination between the intrinsic and extrinsic laryngeal muscle. True or false? Five seconds left. Okay, the answer is true. Daesko stir una. Okay, the last question. Laryngostroboscopy is important to confirm the type of functional dysphonia. True or false? Five seconds left. The answer is false. Okay. So we decide the third just Giovanni, and the second place is Jojo, and the first place and Una. Okay. She actually in our laryngeal department, Prof. So he's a senior in our division, laryngeology. So maybe she get a applause from the from us, Prof.
Congratulations.
Yeah, congratulations. Okay. Is there any other that you can suggest to the resident how to learn about the laryngology?
I think the key of understanding laryngology is you have to understand the anatomy first. Yeah, so I've tested my residents from time to time. I ask them to draw by hand, draw the larynx, axial view, lateral view, where is the cricoid, where is the arytenoid, where is the epiglottis, how is it related to the tongue base, and so on. Then only you can appreciate where is the paraglottic space. You can appreciate the laryngeal pathologies. And the other thing is having good instruments. Examining laryngology is not like examining the nose. You just need a rigid scope, and normally rigid scope give a nice view, and it is just there. But larynx, you have to go all the way down here. So the technique is important, and a good instrument is important to visualize the larynx. If you do not examine properly, you may miss something in the anterior commissure, especially if the patient have retrognathia. Yeah, if you have you don't have a flexible scope, you only have a 70-degree scope, patient gag a lot. Yeah, so that's another problem that you have to encounter. So using 70-degree scope also, there is a skill how you pull the patient's tongue and how you place the 70-degree scope for you to get optimum view of the larynx. Yeah, the first is knowing the anatomy. Second, personal examination until you get a correct diagnosis. And listening to the patient's voice is another key. For example, the spasmodic dysphonia. The moment you hear the voice without looking at the larynx, you know that this patient has spasmodic dysphonia. But you still have to examine the larynx to rule out any other pathologies. Okay.
Thank you very much, Prof. Maybe this is our last session of this today. Mohon maaf lahir batin, Prof.
Mohon maaf.
Happy Eid Mubarak, Prof. Because after this,
Dr. Arfiza sudah frozen. Okay, selamat hari.
Already come to this month.
Okay. So selamat Hari
Sorry, Prof.
Raya.
Yes. Selamat Hari Raya, Prof.
I also want to wish selamat Hari Raya. Maaf zahir dan batin. Sepanjang saya bagi talk ya, lecture, kalau ada yang terlalu cepat, terlalu perlahan, bosan atau salah cakap, minta maaf. Mudah-mudahan Ramadan ini semuanya beri yang baik-baik untuk kita. Ya.
Amin. Amin.
InsyaAllah. Okay. Terima kasih.
Yeah, thank you, Prof. Well, before we go, maybe we can photo together in this Zoom.
Oh, yeah, sure.
Izin abang kakak, izin Prof dan dokter, kita akan melakukan foto bersama dalam hitungan mundur dalam 3 kali screenshot. Izin saya mulai, 3, 2, 1. Dan lagi 3, 2, 1. Dan terakhir 3, 2, 1. Terima kasih.
Terima kasih, Prof. Eid Mubarak.
Eid Mubarak. Eid Mubarak. Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh.